is much safer than wearing contact lenses. Unfortunately, most people don't realize it. It's the same anxiety of driving a car or taking a plane. Most people are afraid of taking a plane, but we know it's 10 times safer. So in this case series we presented, we're looking at some very serious scars, mainly induced by contact lens use. You can see here how dense the scar is. You can see how deep it goes into the cornea. This patient is contact lens intolerant now, especially after she had to go through all this. And again, maybe a missed opportunity by the clinicians who treated the ulcer to switch over to adding corticosteroids. This is always an area of debate. Many clinicians are timid of using corticosteroids early enough because of the possibility of cornea melt and resurgence of the infection. But at the end of the day, you kill the bug, but you kill the cornea as well. So in the past, this, for contact lens intolerant patient, meant the cornea transplant. So we opted to treat this with a topography-guided approach and see how that area of scar for the topographer is an area that has a divot. It's flat. That makes the area around it become steeper by default. And if we go to zero refraction, the laser, in order to normalize this cornea, wants to do a hyperopic correction around the flattened area in order to normalize the cornea. And this is the actual treatment. You have to go, it's quite complicated with topography guided because you have to go and find out how much myopia will this induce. When you use topography guided treatments, the device aims just to normalize the cornea. The topo guided treatment does not have the intelligence to also predict how much this treatment will induce as far as myopia. We all agree that if we treat this on cornea, this will make the cornea steeper in the central and will induce myopia. It looks like a little bit of a decentral hyperopic correction. The trick to do that, if you're using this device, is to equalize C4 in the device's Zernike numbers. If you click on this box right here, Zernike, it will drop down a menu where you see the value of C4 that you're planning and C12. So C12 is standard, it's the asphericity of the cornea. C4 will be 0 here. So if you start adding myopia, not in quarter Doppler's, but 0.05, 0.1, 0.15, you reach a point where C4 and C12 are the same. And that is the myopia that this treatment is planned to induce. So you want to add this to your treatment regimen, to your refraction. So we added the topography neutralization amount, which was about minus 0.15, and the actual treatment was here, minus 425, minus 375 at 25. And this is the outcome postoperatively. You can see that there's still a scar because that was a very deep scar, but it's become less intense. And we have a significant improvement in visual acuity. This is another example, less dense of a scar. This example number 3, is quite significant as well. So a whole series of similar cases. You can see that the area of the scar invariably becomes an area that's flat, and without doing anything in the adjacent cornea, then this part of the cornea becomes significantly steeper because of the gel effect, of the gel mechanical effect of the cornea. So this kind of looks like keratoconus here. But the interesting thing is that the cornea is not thin here. The cornea is thin here because of the scar. So this is the attempt to treat these irregular eyes. This is another one. You can see how dense the scar is, and how deep it is, and how with this treatment, I think in this treatment, we also combine cornea cross-linking in order to address the fact that we thin the cornea quite a bit. And we have found that CXL also reduces cornea scarring. Another thing that reduces cornea scarring clinically is the fact that in these scars, the stromal part of the cornea is very irregular. See how indented this line is here that separates stroma from epithelium? That's why the epithelium is so variable and thick. It's trying to smoothen out this irregularity. Once you do the laser, this edge of the stroma becomes much smoother, and it's my impression that this also has something to do on how keratocytes lay collagen and how further scarring involves. So just smoothing the surface will help that cornea become less scarred. Of course, in our days, we add to corticosteroid treatment, also topical LaserVision, following Steve Wilson's innovation at Cleveland Clinic. Another area of customization we're doing now, for those of you who like PRK, of course, these are ray tracing numbers as well, but what we're doing in PRK, we're using the EBK Orca device here, and see how long it takes me to remove the epithelium, where with this device it takes like 3 or 4 seconds. That's because I'm going to try and carve out only the epithelial surface that fits on my laser the ablation profile. So I'm going to make an effort and only remove the amount of epithelium that's needed to fit my treatment. Of course, this takes a little bit of experience to have a clinical judgment of how wide you should go. And the reason for this is that this is 2 days after procedure, and all these eyes have re-epithelialized. We have a e-poster in this meeting as well. The beauty of this is that if you combine with topical Bronfenac, if you're in the US, that's Prolenza. If you're in Europe, that's Gelux or ESCRS. You get basically, for most patients, a painless first night and very good visual acuity. They only have day 2 blurry vision, and this makes mini PRK a procedure that's very similar to LASIK and SMILE as a result. So we've concluded that this is another way of customizing, not necessarily only the ablation, but also the epithelial removal. And let's go now into some more therapeutic and primary eye treatments. And I think we have how much time? We have another 50 minutes, I think. So this is my history with custom treatments. I was involved early on with Theo Saller's group through IROC and Wavelight designed topographic-guided treatments at the time mainly to treat irregular eyes. So topographic-guided treatments were designed initially to treat irregular eyes, like the eyes you're seeing here. This was my first case ever. This was a broad beam laser case that had a very small optical zone. I mean, no lasers anymore produce such small optical zones, and the patient had significant night vision problems because he had a 7mm pupil. So of course I said, don't worry about it, we'll fix it. I have this new technology that can broaden the optical zone. And that's what we did. We imaged that cornea, we broadened the optical zone. Was the patient happy afterwards? He was 20/20 here. After I broadened the optical zone, he ended up being 20/50. Who wants to guess why his vision dropped? Because the treatment, as you can see here, is a hyperopic treatment in essence. And it induced a doctor and a half of myopia. So this is a harsh lesson of learning really on your first case that topography-guided treatments have no idea of what happens to the refraction of the patient because they take into account no data for the rest of the eye. Ray tracing does. So if we had ray tracing back in 2003, it would have calculated the actual change in the refractive error and place it in. But as I showed you before, today we can do that. If we need to do the same thing, we will go into the treatment and kind of predict what will be the myopic shift of this treatment. This is a similar case than the one I showed you before. These are from my publication back in 2005 in the Journal of Cornea. We presented these at this meeting in 2004. I hope most of you were born by that time. And this was the first attempt back then to treat keratoconus. And at that time, even Theo Saller said, that's unethical. You should never do laser in keratoconus. And now we know this is mainstream. Even at the IROC Center in Zurich, many people do perform surface ablation combined with CXL, what we call the Athens protocol. It's something that's practiced internationally under different names, but we're very happy that many people have moved on the approach of using a very frugal as far as the tissue removing, customized treatment along with CXL, and I'll explain you why. And one of our star patients published here, and this is a true story, this young fellow was a fire department for New York City pilot for the helicopter, for the fire department helicopter. And he had LASIK while he was in the department and developed ectasia. So they took his license away, he couldn't fly anymore. They told him somebody in Greece is treating keratoconus, and he can fix you, he couldn't wear contact lenses. So he came to Greece and said, Doc, listen, my life's dream is to be a pilot. I can't live without flying a helicopter. What can you do for me? I'm like, I can't guarantee you your vision is going to be good enough to fly, but we know we can stop the ectasia and improve the eye. So we did an atherosclerotic treatment on this patient. You can see here the laser ablation. This is putting minimal refraction. This is him before, after, and the difference in the corneal topography at 3 months. And we lost him after that. He was very happy. His vision was 20/20, lost. So, I called a few times, no answer. Patient moved from Queens, and until 6 years later, somebody showed up in our Athens office, also American, and said, hi, I'm a friend of so-and-so, and he sent me here to fix my cornea because I had LASIK and I developed ectasia. I'm like, sure, we'll try. So I'm like, what happened to Nick? He's like, oh, you didn't know? I'm like, no. Well, Nick has enlisted in the Navy, and now he's a fighter pilot. So this is our star case. This is a case that was deployed, actually disarmed as a helicopter pilot in New York City that, I don't know if he's still flying fighter jets, that went on to become a fighter jet pilot. We talked a little bit before about line of vision, and thanks for that question. This is the wavefront studied dynamically in patients back when we thought wavefront-guided treatments are the golden bullet for refractive surgery, showing that your wavefront is dynamic. You don't have a steady, stable wavefront when you're using your vision. It depends where you're focusing, what are you focusing on, if you're following something, if you're fixating on something. So this is a difficulty of choosing the best wavefront map for that specific eye, since there's many different wavefronts that each line you're seeing here is a time plot of the wavefront of each given eye studied dynamically through time. And this study also showed that there's a centroid shift, meaning the visual axis in these eyes shifted a little bit. Another problem to treat. And I think the most important slide I have to show to you today is this: topography modified refraction. And we introduced this in 2015, and I'll show you why. I guess I will, because this paper popped up first. This is our combined surface ablation cross-linking for keratoconus that I was asked by the Journal of Cornea to write an editorial on, since now it's considered one of the ways we formally treat keratoconus. And I took it upon me to search all the literature and include large studies that had done a similar approach, customized surface ablation and cross-linking, and compared the data. Sure enough, found that everybody globally who has done significant numbers with a combined procedure that we call the Athens protocol had similar outcomes. And we listed all these in the October 2023 editorial in Journal of Cornea. And in essence, you can see here the core of the treatment in order to treat the irregularity, the before, after, and difference map, and why we feel this is more robust than cross-linking alone, because we're getting a deeper and more homogeneous cross-linking line. Doesn't show well in this picture, but we're at least 70% depth, very uniform cross-linking line. That's because you remove Bowman's through a large diameter of the cornea, and we're getting a much more significant flattening of the cornea. We're getting an average of 10 diopters flattening and steepening of the irregular part of the cornea, which is impossible to get with cross-linking. Cross-linking usually flattens cornea somewhere between 1.5 and 3 diopters. And the treatments here were about a diopter to 2 of refractive error. So if we added 2, we should have gotten 3.5, 4 diopters flattening. Invariably, we get 8 to 16 diopters of flattening. This is because the 2 procedures are synergistic. When you add them together, they give you far more than each one independently. So let's go. You want to hear how ray tracing works, or should we skip this? We have like 3 minutes. Let's skip it. This is in the literature. I want to go a little bit talking about, this is fixing eye with ghosting with ray tracing. This is an interesting case. This is a Middle Eastern airline pilot that came to us, 51, he has 5 kids, and he started having problems from his keratoconus that he knew all along, except his company did not know he has keratoconus. So he always passed his vision tests 2020, and he came with the impossible task. Dr. Candelabros, fix my keratoconus, and I need to pass a vision test at 2020 without telling anybody that I have keratoconus. We're able to do this in 2-step Athens protocol and then ray tracing enhancement, but that's not always the case. Of course, we discussed with this gentleman that that's an impossible task, and you may need to wear glasses, you may need to have a second procedure. I want to spend a few last minutes explaining TMR. I think this will explain the core on how customized treatments can help patients. Let's go step by step. Let's hear from you guys. Why do we all agree that this astigmatism is regular and with the rule? Anybody who feels that the astigmatism of this topography is irregular and it's not at absolutely 90 degrees with the rule? So I guess this means nobody disagrees with this. Why is it that this patient refracts at 45 degrees and not 180? The waveform measurements are the same, and the ray tracing measurements are the same. The reason this patient refracts at a different axis in the amount of astigmatism is because of its angle kappa. On the x-axis, the angle kappa is only 30 microns. On the y-axis, the vertical axis, the angle kappa is 200 microns. This means this regular astigmatism for the patient is seen like this. So it's tilted through the visual axis. What is a tilted astigmatic lens? A prism. How do people correct for prism if they have a prism in front of them? They choose arbitrary astigmatism to correct that prism, to correct the coma that the prism produces. So in subjective refraction, the patient chooses arbitrary astigmatism to correct the prismatic effect that this normal cornea has on that eye. Now, if you do a waveform optimized treatment, it doesn't matter. This error will transfer from your measurement, the subjective refraction, to the treatment. The patient will be the same. If they're 20/20 with this refraction, they'll be 20/20 afterwards. The problem is that if you do a topography-guided treatment, the topographer is going to try and correct this angle kappa. It's going to try and make this astigmatism go away and the apex of the cornea to match the vertex. Now remember, the apex of the cornea is here, the vertex is here. So these are 2 different spots. So once it normalizes the cornea and makes it symmetric to the visual axis, and we assume the visual axis remains the same, then this astigmatism will pop up, which he always had. So this is the way you can improve optics in a normal human eye by addressing the astigmatism that the cornea has and making the cornea symmetric to the vertex. And this is the beauty of customized treatments. And how do we learn this? We learn this through the irregular eyes, because that's where our manifest refraction had nothing to do with the topographic refraction. And this is something we came up with. We published back in 2015. And of course, back then, everybody thought this was insane, and this was validated with the ray tracing technology that does this automatically. This is another example. You can see that this is relatively regular astigmatism. Angle kappa here is significant for the x-axis. It's 380 microns. So the x-axis is off. See, the astigmatic axis is here. The pupillary center is here. So for this patient, the regular astigmatism is acting as an oblique prism. That's why the waveform data, the topography-guided data rather, is trying to normalize the cornea in this irregular way in order to reshape this and make it more regular to the vertex of the eye. And that's why, let me go click back, that's why the manifest is half a diopter at 160 degrees, where the topographic is 125 to 18 degrees. So our argument was that if you're going to do topography guided and topographer will do this by default, you have to treat the full astigmatism at this axis, and this is a very difficult decision because we're really going away 38 degrees on the axis, and we're adding almost double the astigmatism. And of course, you remove the additional spherical equivalent that this more astigmatic correction that you're doing will perform from the sphere. And this, in few words, is TMR. We published this back in 2015, and nothing validates it more than ray tracing, which in essence does the same thing automatically. So, I think we're out of time. Take a few questions. We got another 10 minutes, I think. We're done at what, 4:30 or 4:15?
I have a question.
Yes, sure.
So